This is Bee. She has her whole life ahead of her. Where will she go? Who will she become? What will Bee's big, beautiful brain be curious about? Well, as Bee began to grow up, she became curious about the brain. How is her best friend Lucy's brain different from hers because Lucy has cerebral palsy? Or when her sister Sasha was hit in the head with a basketball and the doctor said she had a mild traumatic brain injury or a concussion, what exactly happened? And then there was Elliot, her classmate who has autism spectrum disorder. Why was Elliot assigned a teaching assistant? Bee learned that these were conditions of the brain, and as Bee grew even older, she could see that there were brain disorders all around her. The father of her prom date had multiple sclerosis. When she was home from university, her grandmother began showing signs of Alzheimer's. And then a few years later, following the death of her grandmother, and overwhelmed with the stress of medical school, Bee suffered from depression. But to Bee, none of this was surprising. She knew by now that 1 in 3 of us would experience a brain disorder, disease, or injury in our lifetime. And Bee wanted to do something about it. Your donation to Brain Canada will help drive research that will lead to important discoveries of the brain and brain disorders. Your donation might even help Bee, who is a neuroscientist today, engaged in valuable brain research.
Parkinson's disease does not define who I am.
Parkinson's doesn't discriminate.
It doesn't care who we are.
Or how old you are.
Or where we live.
Or what you do.
It does not define me.
I have the support to face it.
I am not alone.
We are not alone.
Parkinson's is the fastest growing neurological condition in the world. Visit parkinsonassociation.ca to donate now.
I have the support to face it.
We can face it.
Our guest speaker today is Dr. Oksana Sucherowsky, who will be presenting an introduction to Parkinson's. So Dr. Sucherowsky has almost 40 years of experience in looking after people with Parkinson's disease. Her career started at the University of Calgary's Faculty of Medicine when she was recruited to develop the Movement Disorders Program in 1984. Under her leadership, the program grew to an internationally recognized center for care of patients with Parkinson's disease and related movement disorders. In 2010, she was recruited to the University of Alberta to expand the movement disorders and neurogenics programs. Her research interests include identifying genetic factors and developing new treatments for Parkinson's disease. She's published over 200 peer-reviewed publications and edited 2 books. She has served as a board member for several decades, first at the Parkinson's Society of Southern Alberta and currently for Parkinson's Association of Alberta. She's also the chair of the research committee. So welcome, Dr. Sucherowsky.
Thank you very much. I'm very happy to be here. I'm going to share my screen now. Is that okay? There. I hope that works okay.
Yep, we can see your slides clearly now.
Perfect. Okay. So I've been asked to just give you an overview of Parkinson's disease. Brandy called it Parkinson 101. So here we go. So the term Parkinsonism is a basic term, although it's named after James Parkinson's, who described Parkinson's disease. It's now used to refer to 3 symptoms: the slowness, which we call bradykinesia. Brady is slow, kinesia is movement; rigidity or stiffness in the limbs; and a tremor at rest. So that's what Parkinsonism means. But it's important to know that there's lots of different causes of Parkinsonism. The most common cause that we see actually is when people are put on drugs called neuroleptics, which are typically used to treat schizophrenia or other psychiatric disorders. And because they deplete dopamine, which is important in movement, they cause Parkinsonism. In people who have strokes, for example, if their blood pressure is not controlled, they'll develop Parkinsonism. And then there's a variety of other causes. So when we see a patient first, we look at the patient's symptoms and medical history overall to make sure that they don't have any of these other secondary causes of Parkinsonism. And once we've made sure that there's no other causes for Parkinson's symptoms, then we can make a diagnosis of Parkinson's disease or some of the related Parkinson degenerative disorders, which can mimic Parkinson's disease. So I'm going to show you a diagram. So if you, many of you, when you come to clinic, we talk about the basal ganglia, or you've probably heard us talk about the basal ganglia, which is where Parkinsonism arises. And if you look at the brain, I don't know, can you see my little arrow cursor on the screen? So here is what we term the gray matter. Okay, this is all the white matter. And then deep in the center of the brain, which is covered by the white matter, is a group of nerve cells called the basal ganglia. And these basal ganglia there's different groups of nerve cells, but you can see that there's a loop that comes from the gray matter, from the nerve cells that control movement. They go through this group of nerve cells called the basal ganglia, and then they come back out. And what the basal ganglia are, it's like a sort of the hard drive of the computer, where it has the computer programs that run the whole system. So while we may have strength, we don't move normally until the nerve cells that control strength cycle through the basal ganglia to get the proper motor program so that we have normal movement. So that's the basal ganglia. Now, in the basal ganglia system, in this loop system, there is a go pedal, which is called the direct pathway, and there's a stop pedal, which is called the indirect pathway. Okay, so it's just like you're stepping on the gas to move, and then when you want to stop moving, you step on the brake, and that's the indirect pathway. What happens in Parkinson's disease is that this go pedal, this direct pathway, isn't working. And it's not working because this part of the brain is not producing enough of a chemical called dopamine. So because the go pedal isn't working, the stop pedal is on all the time. And so that's what causes the slowness of movement, and that's what causes the stiffness, because there's no system to make the system work so that you can move easily and freely. Okay. So that's some basic anatomy of what is happening in the brain. And like I mentioned, dopamine is the main chemical that is not produced within this system to make the go pedal work, which is why Cinemet, which basically is made into dopamine, why it works so well. So we're stimulating the go pedal to make your movements easier. Okay. Now, this system within the basal ganglia doesn't just connect to the motor nerve cells in the brain. It also connects to other groups of nerve cells. So as you can see, it's a complex system. So we were talking about the motor cortex, which is the nerves that control movement, but it also is connected to the frontal cortex. And the frontal cortex is where a lot of our thinking and memory, making decisions and judgments is. So just like sometimes people find that they move slower, they also think slower. When their medications are not working, people think slower because it's also a go pedal for this thinking system of the cortex, of that part of the brain. It also connects to the limbic system, and the limbic system is our emotion group of nerve cells. So the emotional, so some people with Parkinson's can get depression, can get anxiety, because the emotional center is also connected to this basal ganglia. So that same chemical called dopamine is involved in the emotion system in the brain, which is further down in the brain. So like I said, while we talk about motor symptoms a lot, it is really a much more complex system. And that's why when you come to our clinic, very often we will ask you about how you're feeling, how you're thinking, whether you have depression, whether you have anxiety, and other symptoms, because it's quite a complex system of what the basal ganglia do. Okay, so that's just a bit of background on sort of the basic chemistry and physiology and anatomy of what happens in Parkinson's disease. Now, when somebody comes to see a neurologist, the diagnosis of Parkinson's, like I said, first starts with making sure that you don't have strokes, that you don't have a tumor, you don't have other conditions. And that's why we would order a CAT scan of the brain or a magnetic resonance or MRI scan of the brain. So we do those. They don't make a diagnosis of Parkinson's disease. They rule out other causes that could cause Parkinsonism. But once we're sure that there's no other causes, then we make a clinical diagnosis. So it's still good clinical examination and assessment that makes the diagnosis of Parkinson's, making sure that people do have stiffness and slowness. And some people may have a tremor at rest. Now, not everybody with Parkinson's has a rest tremor, but many people do. The other symptoms of Parkinson's, which is unique to Parkinson's, is that it always starts on one side of the body. And as symptoms progress, then the other side becomes affected, but it always starts on one side, not both sides at the same time. We don't know why that is, but that's very typical of Parkinson's. The other way we confirm the diagnosis of Parkinson's disease is that when you are started on a medication like Sinemat or Levodopa, which it contains levodopa, that the symptoms get better. So that's how we make a diagnosis of Parkinson's disease. Number one, we make sure there's nothing else going on. Number two, that an individual has the typical symptoms of Parkinson's. Number three, that it always starts on one side. And number four, that you get better with Sinemat or Levodopa. Okay. So Parkinson's is present worldwide in all ethnic and groups. And it is very common in people as they get older. So 1 in 100 individuals after the age of 60 will get Parkinson's disease. It's 1 in 100. It's very similar to Alzheimer's disease. It's also 1 in 100 of people over the age of 60 will develop Alzheimer's. Why do people get our Parkinson's? Well, we still don't really know in most cases. We do know that genetic factors play, that there are some genes that are involved, particularly the younger you are, the more likely it is to have a genetic problem to cause Parkinson's. We think there are environmental toxins, although no one has ever shown what exactly those toxins are. We know that if you grow up in a rural environment on the prairie provinces, your risk of getting Parkinson's is higher than if you grow up in an urban environment. In Hawaii, if you eat a lot of fruit, your risk is higher than if you don't eat fruit. In China, if you grow up in an urban environment, your risk is higher than if you grow up in a rural environment. And a lot of money has been spent looking at these factors, and nobody's really found what these environmental factors are. But the biggest risk factor, obviously, is just getting older. So I already covered that. I think I'm not going to go into this in more detail. This has been just some of the theories, that it's manganese in the soil, that there's other pesticides, etc. But like I said, nobody really knows. Now, this is a slide just to show you of the genes that are involved. So as I've said already, the younger you are, the more likely you are to have a genetic problem causing your Parkinson's. And these are well known already. We have some people in Alberta actually working on genetic factors, both in Edmonton and in Calgary, trying to determine the specific genetic factors and what they do. But it mainly is, like I said, it's mainly young people. If you get Parkinson's in your 30s or 40s, I would arrange for genetic testing, and we do find the genetic cause. The older you are, the more likely we think that it is an environmental factor that is involved in Parkinson's disease. But in most people, it's a combination of both. We think that there may be some genetic predisposing factors, but in most individuals, we don't know. But what can you do to decrease, if you don't have Parkinson's, what can you do to decrease your risk of Parkinson's? Well, the number one thing is, I'm sure you've all heard multiple times, is exercise. So they took 1,000 middle-aged men and looked at whether they exercise or not regularly. And if these middle-aged men exercise regularly, their risk of getting Parkinson's 10 years down the road is decreased. So we know that it decreases the risk of Parkinson's. We also think that maybe if you exercise regularly, that you can slow down progression of Parkinson's disease as well. And of course, in both in Edmonton and Calgary, there's a lot of research going on that some of you may be participating with Ambulisono to see if regular exercise helps treat Parkinson's disease. The other thing, if you drink coffee, your risk of Parkinson's is lower than if you don't drink coffee. And also if you smoke cigarettes, the risk is lower. We don't know what it is in these two. We don't know what causes this association. I certainly don't recommend anybody to start smoking, but you might want to have a cup of coffee or two. So the next question is, when and where does Parkinson's begin? So one of the big advances in Parkinson's research over the past decade, I think, is that Parkinson's disease doesn't begin when you have motor symptoms. When you have the tremor and the stiffness and slowness, that is now considered to be the middle stage of Parkinson's. And we know that the changes in the nerve cells that cause Parkinson's disease actually begin probably in the gut, in the small nerves in the gut, or in the small nerves in the nose. And so people who develop Parkinson's, if you ask them, will admit to developing constipation or maybe losing their sense of smell. And this happens 5-10 years before they develop symptoms of motor symptoms of Parkinson's, the tremor and the slowness. Okay. The other thing that happens is that the changes in the nerves also affect the brainstem, and the brainstem is this lower part of the brain here, and it affects groups of nerve cells which affect sleep. So people start getting problems with sleep. They affect the limbic system. And remember, we talked about that's sort of the emotional center of the brain, which is sort of down here, and that people will get anxiety and depression. So it looks like what happens is that, first of all, the first symptoms of Parkinson's may be loss of smell, constipation. Then you get problems with sleep, and it's called REM sleep disorder, so that you act out your dreams when you're asleep. Then you may get anxiety and depression. And then finally, as it comes up to the basal ganglia, which is the stop and go pedals, that you get the motor system of Parkinson's disease. So a lot of the research now is looking at people who develop these problems, as I mentioned, 5-10 years before the motor symptoms, because if we want to stop people from getting Parkinson's, that's probably where we have to intervene. That's probably So there are researchers, for example, at McGill that are looking at people who develop sleep problems that we know have a high risk of getting Parkinson or showing up with Parkinson symptoms several years down the road, to see if anything can be done to stop them from getting the motor symptoms of Parkinson's. So I think this really is a relatively new concept of when actually the symptoms of Parkinson's start and how they start. Okay. So now I'm going to move to treatment of Parkinson's disease. Okay. So the main treatment is a drug called Levodopa, which is made into dopamine by the brain. And the two drugs that we have in Canada are Sinemet and Prolopa. And before we had these drugs, people used to die from Parkinson's within about 10 years. With this particular medication, which is still the best treatment for Parkinson's, it is not toxic and it works for the duration of the problem. We have people living for 20, 30 years with Parkinson's disease with good treatment, with good benefits for the first 10, 15 years in many cases. So this really has changed. So people don't really die from Parkinson's disease anymore. They would die because of heart disease or diabetes or strokes or tumors, other causes. Now, as I mentioned, Levodopa is the drug that we use, but Levodopa can't get into the brain, Levodopa is changed into dopamine, which is the chemical that the brain needs, by the body. So if we just give somebody Levodopa, the liver will change it into dopamine and it won't get into the brain. So we have to keep Levodopa here as Levodopa so it can get into the brain, and then the brain makes it into dopamine, and then the basal ganglia can use it physiologically. Okay. Oops. So the reason why you're not on Levodopa but on Sinemet is because Sinemet contains a chemical that prevents the Levodopa from being made into dopamine. And Prolopa also has a different chemical, but it has the same effect, so that the liver can't make it into dopamine and the Levodopa can get into the brain. There's also another compound, another enzyme that breaks down Levodopa into dopamine, which is called entacapone or Comtan. And so some of you may be on Sinemet or Prolopa and entacapone or Stalevo, which is a combination of all three of these chemicals, Levodopa, a DD, and a COMT, so that as much Levodopa stays as Levodopa in the system and get into the brain, where the brain then can use it as dopamine. So that's why you're on these combination pills, is because pharmacologically, it's the best way we have of getting Levodopa into the brain. Okay. Now, so like I mentioned, we need to get dopamine into the brain to make that go pedal work. And the best way is the Levodopa drugs that I already mentioned, in combination or by itself. And then there's another group of drugs called dopamine agonists. So they mimic the action of dopamine. And sometimes we use the two together because Levodopa itself doesn't last very long in the blood before the body gets rid of it, whereas these dopamine agonists have a longer term that they last in the blood. And these are MAOB inhibitors. And if I can go back the slide, so MAOB, so it works in a different place. So once we get Levodopa into the brain, we don't want the dopamine broken down by the chemicals in the brain. And so you can see this MAOB. So that's where rasagiline and selegiline work. So they stop the dopamine once it's in the brain from the brain getting rid of it and to stay as dopamine. So it's sort of another, and that's why, people always say, why are we on all these medications? It's because we use them all in combination to try and get as much dopamine to work in the brain to last as long as it can. Okay, so that's sort of a basics about treatment. Now, I already mentioned some of the problems that happens in Parkinson's disease before you get motor symptoms. But as the motor symptoms appear, that you also get, it's called the autonomic nervous system is also affected. So that's another part that we haven't talked about yet, but there's another part of the nervous system called the autonomic nervous system, which is mainly in the brainstem and in the spinal cord, which controls our heart rate, our blood pressure, and bladder and bowel function. And so that the autonomic nervous system is affected. And so your bladder speeds up. You can't control your bladder. When you have to go, you have to go. You go frequently during the day. Sometimes you have to get up at night, but the bowel slows down. So your gut slows down and you get constipation. Your bladder speeds up and you have to go all the time. So those are the autonomic nervous system that's involved in Parkinson's. Also causes sexual dysfunction and also causes low blood pressure. And some of you may remember that when you come to clinic, we take your blood pressure lying and standing because the blood pressure can fall when you're standing, and some people faint or pass out when their blood pressure falls. So this is not an uncommon problem, low blood pressure in Parkinson's disease. And frequently, if you have high blood pressure and are on blood pressure medication, when you get Parkinson's disease, you need to either decrease the blood pressure medication, or we have people that come off it altogether because their blood pressure is now low or normal, so they don't need blood pressure medication anymore. We always try to educate the family physicians about this, that to take blood pressure lying and standing and to decrease blood pressure medications if the Parkinson's gets worse, you need to decrease blood pressure medication. We already talked about the psychiatric issues that may come on either at the beginning of Parkinson's or develop later on, the sleep disturbances, which are very common, falling asleep, waking up in the middle of the night, acting out the dreams. And this is in part of this is normal aging, but it's made worse by Parkinson's. And then lastly is fatigue and apathy. So this isn't just because the medications aren't working. Some people just don't feel like doing things, and that's part of the condition as well. So it's important to recognize all this. And a lot of these things we can treat. For example, sometimes we can't treat apathy, but fatigue, there are some medications for that. Certainly anxiety and depression, we have very good medications for that. The sleep disturbances can be treated with a variety of methods. And then we can slow down the bladder, we can speed up the gut if we have to, we can help the sexual dysfunction, and we can help the low blood pressure. So the treatment of the non-motor problems is just as important as treatment of the stiffness and slowness, and causes just as much decrease in quality of life as the motor symptoms of Parkinson's disease. Other treatments, of course, we refer our patients to Parkinson's Alberta. I think very good programs and activities. Recommend exercise. We have a physiotherapist, Susan, that works with us in clinic that assesses the patients for gait and balance problems. Very important, as I mentioned, to exercise regularly, at least 30 minutes a day or an hour every other day. And just going for a walk with your dog for 20-30 minutes a day is sort of the minimum that you should be doing. That very, very important. Calcium, so some people, because their activity is a bit less, may get osteoporosis. So important to talk to your family doctor about whether you should be in calcium. And lastly, I recommend that you take calcium and vitamin D. The D somehow got left off. Calcium and vitamin D, and everybody in Alberta probably should be on vitamin D anyways. But the B vitamins are very important. Because levodopa, when the brain is making levodopa into dopamine, it actually uses up the B vitamins, so that if you're on high doses of levodopa or something like duodopa, you should be supplemented by B vitamins, because if you're not, sometimes you can get nerve damage in your feet. So that's also very important. Okay. Now we know that over time, the levodopa, as the condition progresses, that the benefit of the Sinemet is decreased. So we do need to use multiple medications. I already went over some of the combinations that we use and why, to increase the amount of levodopa available, the amount of dopamine that is in the brain. People lose their normal gait function. And this again is in part normal aging, but made worse by Parkinson's disease, so that you can't, your balance isn't as good, or you may get stuck with freezing of gait when you're walking. And so there is a real risk of falls. And that's why we recommend physiotherapy or use of cane and walkers if things get worse. And people also develop some problems with swallowing. So we work with the speech therapist to assess that. If they get low or quiet speech, again, the speech therapist can help. So there's a lot of other medical disciplines that we work with to provide care for patients. Of course, our nursing staff at the K is very important and provide a lot of education as well as help with different problems. Social worker and Dr. Perez Parada, who is our psychiatrist that works with us to help manage the depression and anxiety and other issues. Two other modalities that we have in Alberta. The first is the surgery, the deep brain stimulation for Parkinson's disease. And that's just a little diagram of where the electrodes go into the brain. The surgery is done while an individual is awake. So the brain has no pain sensor. So you can put the electrode in, and we only need to freeze the scalp and a little bit of the skull, and the size of a quarter of the scalp and skull is taken off, and then the electrode is put into the basal ganglia, which we talked about already. And generally the neurosurgeon and the neurologist involved which is Dr. Bond, Dr. Shetty now, would decide on where the best place for this electrode is, and then it provides a constant small electrical current to stimulate that part of the brain, and it helps the symptoms of Parkinson's disease. And sometimes, depending on where the electrode is, we can also even decrease the medications that an individual needs. So that surgery is available. It's generally done in younger patients because older patients over the age of 70, 75 have a higher risk of hemorrhage. You know, when we put in the electrode, there's a risk of causing a small hemorrhage in the brain, and that increases as you get older. But that's available. And then the next one is duodopa, which is what the program that I'm involved in now with Dr. Shetty. And that's putting in a little tube into the stomach, which goes down into the gut. And the little cassette contains levodopa. So in a little pump. So the levodopa is just given constantly through the little tube into the small intestine, where it's absorbed. So it maintains a constant blood level of levodopa. So it works much better, because if you take a pill, by the time it gets absorbed, you get a bunch of levodopa being absorbed, and then you don't have any for several hours, and then you take another pill, it's absorbed, and then you don't have any for several hours. So there's this. So it works, it doesn't work, it works, it doesn't work. Whereas with duodopa, or also called L-Sig, that the levodopa is provided in a small amount, but constantly. So you have a constant blood level and a constant brain level. So we're doing this for patients who don't want DB, so where the medications aren't working as well anymore. that we're giving it, and they don't want or can't have surgery, then Duodopa is a good option. And I should mention that this is a little tube that needs a gastroenterologist to put the tube in, but the company, there's a company that is making a subcutaneous form of Levodopa. So we may be able to have a patch where it's just given under the skin rather than a tube into the gut. And I believe this has just become available in the United States. Can't remember if it's just become available in Canada, in the US or Europe, but we understand it is coming to Canada in the near future. So that would be available. So you don't have to have, you still have to have this little pack, but you don't have to have the tube into the stomach. So now as the condition progresses, then of course, there's more adjustment of medications. There may be more side effects, in particular because the frontal cortex, the thinking part of the brain, is more involved, that people may start to get more, not just slowness of thinking, but some actual memory loss. And they may start to have visual hallucinations. And these hallucinations are usually animals or people, and initially they're not threatening. And these can be treated as well in a variety of methods, usually a medication called quetiapine or Seroquel, which stops these hallucinations. Sometimes we also use some of the Alzheimer's drugs that, that we use as well, and they will help memory loss and Parkinson's as well as decrease the hallucinations. So some of the same medications that we use to treat Alzheimer's are very useful in Parkinson's as well. But unfortunately, over time, if the condition does worsen to the point where there is a lot of there's not a good response to medications and there's memory problems, that sometimes the individual does need to go into a long-term care facility. We still continue to see our patients if they go into long-term care facilities. It's not like you don't get care anymore. We still see everybody and continue to work with the family doctor to adjust the medications. And we can't forget caregiver burden, that some individuals do require quite a lot of care in the home, and the caregivers are very important, and support for caregivers is needed as well. Okay. So I'm getting in there. I'm sure there's usually questions, so I'm happy to take any questions. So a quick overview of Parkinson's disease, and it is one of the most common disorders of aging, and that the loss of nerve cells begins 10 years before the symptoms, the motor symptoms that we think of as Parkinson's disease. With the medications, we have good symptom control for 10, 15 years, but certainly the medications that I talked about work for the duration of the disorder. You do not get immune to levodopa. You don't get toxic from levodopa. It replaces the chemical, the main chemical that the brain can't make anymore. So it is actually the natural replacement. It is the actual chemical that the brain can't make anymore. It's not an artificial drug. Okay. And, in Alberta, as well as in Canada and around the world, there is a lot of research going on to try and determine the cause of Parkinson's, to improve treatments, and ultimately to slow down or prevent Parkinson's disease. And this is just a little slide of the research studies in Alberta that many of you, I hope, are participating in. See open our database, which is Canada-wide, the music and exercise studies done by Dr. Kamacholi and others with Anambulisono, and Dr. Who, problems in gait and how to improve it. Dr. Sankar is working on improvements in surgery. I'm doing research on Duodopa in patients. We have a basic scientist on main campus looking at a vaccine for Parkinson's, Dr. David Park in Calgary, and I'm blanking on the name of the researcher in Edmonton at U of A that's working on genes that can cause Parkinson's disease. And then finally, Dr. Miyazaki has the palliative care program. So as you can see, in Alberta, we are very active, not only in treatment of patients, but in research in Parkinson's disease. And we are very grateful for our support from Parkinson Alberta. Parkinson Alberta does support a number of these research projects, and we're very grateful for that. Thank you.
Wonderful. Thank you, Dr. Sucherowsky. I've got a few questions here. So I'll field the first one here about vitamins, and then I got to grab my computer charger because it apparently this one isn't working. So the first question I have here is, can you just take a multivitamin? You mentioned a couple different vitamins, or do you need the 4 individually? And if you had a specific kind of strength and timing when they're supposed to take these medications?
Yeah. So good question. So for calcium, you should talk to your family doctor because the regulations keep changing. And so the family doctors will know more about how much calcium is recommended and if it's recommended for you. Because sometimes with heart disease, I think they may not want you to take calcium. So calcium, that's up to the family doctor. And regular exercise, again, will help to prevent osteoporosis as well as calcium. Vitamin D, there's different recommendations. I would say between 1,000 and 2,000 international units a day is generally recommended. Now you can take it anytime. And the B vitamins, yes, just a good B vitamin is fine. There isn't any sort of B vitamins are water soluble, so it's hard to take too much B vitamin, but generally a good, a Centrum or something like that is fine. Whatever B vitamin, B complex is fine. And it doesn't matter when you take the vitamins compared to when you take your Parkinson's meds.
Excellent. Thank you. Next up, I have, what strategies do you recommend for somebody with diphasic dyskinesia?
Yeah, so that's diphasic dyskinesia are difficult to treat because it's when you first take Sinemet or Levodopa, then you get dyskinesias, and then the dyskinesias go away, and then the dyskinesias come back as the Levodopa is coming out of your system. So taking smaller doses more regularly sometimes works. We certainly would put you on amantadine. So amantadine, I didn't mention it before, but amantadine is a drug that for anybody with any kind of dyskinesias, the amantadine helps with dyskinesias. The deep brain stimulation can help. But basically, it's working with your neurologist to adjust the medications. And I should mention, of course, dopamine agonists, because dopamine agonists last longer in the blood, so you don't have the fluctuations. So it's a combination of a long-acting dopamine agonist, for example, the rotigotine patch, taking smaller doses of Sinemet very frequently, DBS. It's tough. This is a tough form of Parkinson's to sometimes get under good control. But I think with many patients, we can get it. We can certainly improve function, but it does take some work and some trial and error sometimes to see what works best for the individual patient. I should say that Duodopa does not work for diphasic dyskinesias. We've had several patients on Duodopa, and it's not helpful.
Thank you. Next up, I'm on venlafaxine, which I believe has tremors as a side effect. Is there a better medication or alternative medications out there?
Yeah, I'm sorry. This is a personal question that you need to discuss with your neurologist or family physician. So we do use venlafaxine in general. In many people, it does not make tremor worse. So you have to determine whether in your particular situation it makes tremor worse or not. But there are lots of antidepressants. So this is there's lots of antidepressants out there. So there's a lot of different choices.
Excellent. Thank you. I have one here. So has there been much research into atypical Parkinson's where the mental symptoms are more significant than the physical symptoms?
Yeah, so there's three main types of what we call the atypical Parkinsonisms. So those are called, so as I mentioned, once you rule out causes of Parkinsonism, Parkinson's disease is the most common degenerative disorder, but then there's three others. One is called corticobasal degeneration, one is called progressive supranuclear palsy, and the third is called multiple system atrophy. They do not respond to levodopa as well as regular Parkinson's disease, although we still do use it in many cases. And then the treatment is basically the same as Parkinson's disease, where we would use, they may have depression, they may have anxiety, they may have memory loss. We would use the same groups of medications to treat that. There is research now that we recognize that there are three atypical Parkinson's conditions. There are specific research groups, like we all belong to the Parkinson's study group, which studies Parkinson's disease, but there's a CBD research group, there's a PSP research group, which is very active in Europe in particular, and an MSA research group. So these groups are all doing similar research to what I showed you in Parkinson's disease, but in those specific subtypes, because we can diagnose them better. Now, those three groups, we can use MRI to help us with the diagnosis as opposed to Parkinson's disease. The pathology is a bit different. The causes are different. There don't seem to be genetic factors in those three, the way there are in Parkinson's disease. So yes, there are active research groups in those three conditions. In our clinic, or any neurologist would treat all four conditions. And like I said, there is overlap in the treatment. One of the problems with research is that they are significantly less common than Parkinson's disease. So if you take all Parkinson's disease, about 80 to 90% will be Parkinson's disease, and the other 10 to 20% will be the other three conditions. So you can see that they're much rarer, and so it makes it more difficult to do research.
Thank you. I think these two might go hand in hand, because I got two questions around. So someone heard there is a way in the States they're doing like a lab test, which I believe is this DAT scan that has also come up in the chat. And is that a credible way of diagnosing Parkinson's? And is it coming to Canada if it is?
Well, we do have DAT scans here already, and we do have PET scans. So PET scan is probably the most, so we can do a PET scan now. It's been available. Actually, Edmonton's had a cyclotron for many years, for decades, actually. So we can do a PET scan. So I think we tend to do a PET scan if we're not sure of the diagnosis. If we're not sure, for example, sometimes patients develop memory problems and some symptoms of Parkinson's, and sometimes you might not be sure whether it's Alzheimer's. The main problem is Alzheimer's or Parkinson's, not common, but sometimes we can do a PET scan, which is a radionucleotide scan, which is at the Cross. So we have PET scanners available, which we've been doing for quite a while, actually, in Edmonton already. And so that's the best way of helping us. Sometimes if we don't have if we're not sure of the diagnosis, DAT scans are good, but they're not as good as PET scans, and we already have a PET scanner. And I can't remember if the Royal Alex maybe was planning to get a DAT scan, but like I said, we have PET scanners. We have the best already.
Excellent. Thank you. And then I've got one here. So does Parkinson's present differently in women than men?
Yeah, that's a very good question, because in fact, I did some research on that a number of years ago. So women get Parkinson's less commonly than men. So it's 60-40. So 60% of, like, if you look at our clinic, it'll be 60% are men with Parkinson's and 40% are women. So women have a lower risk. They might have, the symptoms overall are the same, but women may progress slower than men. And they also may develop more dyskinesia, the writhing movements, a little bit earlier than men. So when you look at, say, thousands of patients and you look at the statistics, it's different. But on an individual basis, it's really not that different. The thinking is that maybe estrogen is protective in women, and that's why women don't get Parkinson's as often. But like I said, on an individual basis, I wouldn't say it's really different, but certainly there are some differences between men and women in, like I said, rate of progression and the risk.
Excellent. Yeah, well, win for the women there, I guess, if estrogen is a protective factor.
That's right.
I've got one last question here that popped up. So I experienced sleep concerns, particularly around kind of flailing around in my sleep. Is there some ways I can help stop that, or at least protect myself while I'm sleeping?
Okay, so that is the sleep disorder that I was talking about. That's called REM behavior sleep disorder, or REM sleep behavior disorder. What happens when we're asleep and we dream, our brain, the brainstem actually paralyzes us, so we don't act out our dreams. Okay, or we don't start sleepwalking or something. So when we're dreaming, we're basically paralyzed. And when we stop dreaming, the brainstem turns on the motor system again. And what happens in Parkinson's disease is the brainstem isn't shutting off the motor system when you're dreaming. So you're not paralyzed anymore when you're sleeping, when you're dreaming. So when you're dreaming, you're flailing limbs and you can be talking, you can be doing things because you're not paralyzed when you're dreaming. So you're acting out your dreams. Okay. And that's a well-known symptom of Parkinson's. So we can't fix that. And we can't turn on and off the brainstem. That happens automatically. So we can't fix that. So I think the only treatment really is to pad, if there are bed rails, to pad the bed rails. And sometimes people do have to sleep in separate beds, or get mattresses. In Europe, you get mattresses that you can push together, but they're separate. They're two singles that you sort of push together so that one person doesn't interfere with the sleep of the other person. But unfortunately, I have had patients that have punched their spouse in their sleep because they're dreaming, they're acting out their dreams. So, but we don't have any medications to treat that. So like I said, most people just have, like the old TV shows, where there were two single beds. People never slept together in the TV shows in the 50s. That's probably the best treatment.
Excellent. I've got one more that just came in. So my mom experiences pins and needles kind of pain on her arms, mostly at kind of 4 a.m. to 5 a.m. in the morning. Is there something that can help kind of reduce that or treat it?
Yeah, again, it's sort of hard to answer personal questions like that, but it may be that the Sinemet or Prolopa is wearing off, and it may be the first symptom of the medication sort of getting low in the brain. And if that's the case, but again, you need to talk to the neurologist to sort that out in more detail. But some people do find that they do get stiff or during the night or other, and that just taking an extra Sinemet during the night can help with that.
Fantastic. I think that covers all the questions that I got here in the chat. Lots of thank yous coming in. This has been wonderful. So I want to thank you, Dr. Sucherowsky,